Hello, everybody. My name's Dr. Jackie Dyer, and I'm happy to be here to help to chair such an important webinar on the risk to human rights in the context of mental health and COVID. And I'm going to move briskly along, actually, because we've lost some time due to what is quite normal in this time around technical difficulties, but we're glad that you've all managed to get through just now. And I just want to sort of reinforce how important it is within the context of COVID-19. We've all shared a very challenging time in our history, and the interactive effects of COVID on all ages, on our lives and livelihoods, has manifested in an array of impacts on our emotional health and well-being. And so it's timely that we think about mental health and COVID and the risks to human rights, and how important at this time staying true as professionals, especially in this field, to supporting the effective implementation of our human rights and equalities, I would add. So without further ado, many of you know me. I'm the Mental Health Equalities Advisor for England and the President of Mental Health Foundation and the chair of founder and chair of Black Thrive. I'm also quite essentially a lived expert by experience. Without further ado, I will go to Andy Bell, who I'll leave each of the presenters to introduce themselves.
Thanks, Jackie, and thanks everyone for joining us after a bit of a challenging start. So I work at Centre for Mental Health. We're an independent organisation. We've been around for a number of years. Hopefully you know about our work. If you don't, do take a look at our website and resources afterwards. But our work is really about bringing evidence to bear to ensure that we can reduce inequalities in mental health and really start to challenge some of the long-standing and entrenched barriers in society to having a good quality of life for everybody. Since the pandemic started, obviously we've all been working at home, and clearly we're going to be doing so for some while. But more importantly, we've turned our attentions to looking at what's going on for mental health, both for the mental health of the public as a whole, but also the lives of people living with mental health difficulties, and really focusing on not just in inequalities, but where there are real gaps in support, making sure that we can bring issues to the attention of people in positions of power as quickly as possible, and challenging some of the inequalities that unfortunately we've seen. So some of the key areas of concern, and there are a lot of them. I will share the website link when I'm not talking, just to respond to the question in the chat. Thank you for that. So there are undoubtedly direct impacts of the virus on people's mental health, and that is certainly the case for people who have experienced the virus itself, and indeed people who've been bereaved. And for a lot of people, bereavement during this time, whether it's from the virus or not, will be an extremely complicated and difficult process, and we really need to make sure that we support people who have been bereaved during this time, whatever the cause, and that will require some work longer term. We also need to look at where the burden of the virus is greatest, and on groups of people whose mental health are likely to be more affected. And that can either be, again, by the virus itself, and particularly minority communities where we're seeing very, very high rates of serious illness and mortality, but also those who've been affected by the side effects. So those living in homes where there is violence and abuse, those who are faced with threats to their livelihood. We're particularly worried about young people, because we know that youth unemployment has a lifelong scarring effect on people's mental health. We need to be incredibly attuned to that. We also need to look at what's happening in the prison system. Hasn't been talked about much, but there's been a great effort to keep people safe from the virus in prisons. As a result of that, we're seeing people being locked in their cells for 23 hours a day. And the mental health effects of that, both immediately and long term, on people who are in custody at this moment, need to be taken extremely seriously, and we need to look at how we can support people longer term who've been through that. And indeed, as we start a second wave, we need to be sure that people are kept both safe psychologically as well as physically in custodial environments from now on. We can't just leave people in extremely vulnerable situations. I think we also need to look particularly at the impact on people living with mental health conditions at this time. One of the things we've been able to do as a charity that is observing and keeping an eye on developments is see some very serious challenges coming through. Many people saying that they can't get hold of basic things, particularly during the lockdown. In the initial help from government, people with mental illness were not included in the list of those who could get help with access to food and prescriptions. Thankfully, that changed, but we need to ensure that more help is available for people living with mental health conditions to get access to food and essentials if we have further lockdowns. We also need to ensure, of course, that mental health services are able to continue. There's been a real mixed picture, very different views about whether mental health support has continued at the same rate as before. There's certainly been some interruption, there's certainly been some shifts, but there's very different stories coming from services to what we're hearing from people who are struggling to get help. And then we need to look at the effects on physical health of people living with mental health difficulties, both in terms of being a group of people who already have poorer physical health, but adding on top of that the break in the provision of health checks, and particularly I think help with smoking cessation clearly is more important than ever for people that want to give up smoking. So there's loads of things we can do. I shan't go into lots of detail because we need to keep this thing moving, but we must plan now. We know winter's coming, we know winter's going to be tough for our mental health, and we need to ensure that mental health support is provided wherever and whenever it's needed. We need to ensure that we create places that are trauma informed, that respond to the fact that we've all been through a collective trauma, but those experiencing poor mental health and those who've had past traumas, it will be greater still. So whether we're looking at schools and colleges, whether we're looking at workplaces, prisons, hospitals, care homes, and indeed mental health services themselves, they need to come with an understanding of what trauma looks and feels like and how to respond safely and appropriately to people that have been through so much, including, of course, staff. We do need, as soon as possible, to repeal the Mental Health Act changes in emergency legislation, and I'm sure other speakers will talk about that. I certainly hope so. It's so important that we do not take the step of reducing people's safeguards unless it is absolutely essential. And as soon as we can, we need to scrap that piece of legislation and get on with modernising the Mental Health Act on the lines that Simon Westley's report talked about. And we must make sure that people living with mental health difficulties get fair access to flu jabs. We know immunisation against flu is important. We know there is a risk of a winter flu alongside COVID, and we must make sure that people with mental health conditions are not left out, and particularly those experiencing poor physical health as well. That needs to be a proactive effort. We must not leave this to chance. There's a lot more I could say, but I've had my time. And Jackie, back to you.
Thank you so much, Andy, for a sort of comprehensive overview of all the sort of range of contexts where paying attention to human rights is really critical, and outlining some of the challenges across our society that we're facing in relation to mental health and COVID. I'd like to Daniel to come in at this point, and perhaps Daniel, for you to also include in your presentation, as Kevin, as I would ask of Kevin, is a sort of emphasis of what do we actually mean by human rights within these contexts, which is what I believe that you're going to help us to peruse and consider. So I'll hand over to Daniel Dalton. Please introduce yourself.
Thank you, Jackie, and thank you very much to GovConnect for this opportunity to try and add a bit of clarity and insight into some really complex issues about how we make sure that we do put people's rights first and foremost at the front of everything we think and do. It's a great opportunity for us to describe the work that NHS England has been doing to try and guide and shape clinicians in their day-to-day decisions, and also the service users and carers of service users. I'm Dan Dalton. I'm a National Specialty Advisor for mental health. I'm a forensic psychiatrist by background. I'm also a medical director for a mental health trust in the east of England. And most of my work in NHS England relates to the specialised mental health portfolio. But during these extraordinary times, I've had the opportunity to work with others to think about how we provide continuous and excellent services to people with mental health treatment needs. I also would like to particularly mention and give thanks to Ruth Davies, who's our adult acute mental health programme manager, who's done an extraordinary piece of work pulling together I'll just try to work out how to put my slide forward, forgive me, pulling together some of the views and opinions of others, particularly people who use services and clinicians, to develop some guidance. And I will make reference to this guidance a couple of times, but I strongly encourage people to have a look at the guidance we developed during the first wave, but also to think about the iterations that are yet to come, which will hopefully give some clarity in some of the areas which have caused the greatest anxiety to people. So what do we mean by human rights in this context? So mental health services have always had to balance the autonomy and rights of the individuals with a duty of care towards those people and a duty to protect the public from harm, and do so on a day-to-day basis using familiar approaches to understanding what's right for the individual, and providing frameworks that give clarity to professionals so that they can work alongside the people in services to make those decisions is critical to ensuring that whenever we make a decision for anyone who's in our care or with that person, we do it in a way which is lawful, proportionate, and likely to achieve the effect that we're seeking to achieve. And with those three fundamental questions in mind, we can assure ourselves that we are making decisions which respect and promote the rights of individuals who are using our services. Without clarity, there's a danger that clinicians, people who use services, and others become overwhelmed by a need to impose blanket restrictions or to restrict rights in a way that doesn't actually lead to better care. And what we fundamentally want to do is to give that clarity to people so that they can make the decisions that are right with those individuals in services. And one of the things I think I'm going to reference a few times today is that the answer to that is always making decisions on a case-by-case basis. So although clarity involves setting out very clear expectations about what is right and what is not right, what's right for one individual will be about them, their circumstances, and the balance of harm of making a decision one way or the other. And I think our guidance does a good job of helping people to understand that and make decisions that are lawful and appropriate within that context. So I think what I want to do, rather than going into some of the details, is just rehearse some of the reasons why we need to talk about principles more than we talk about processes. So we've made huge strides forward in mental health services. We've still got a long way to go, and absolutely right, as Andy says, that until we realise the contents of the Mental Health Act review, we're still going to be just looking at an improvement that can be delivered in our legislative context. But actually, the progress that we've made in moving away from institutional and restrictive practice towards a realisation that the right way to provide care and treatment to people is making decisions alongside them, setting realistic and shared goals with people, and ensuring that we enable and empower people who use our services to be informed partners in our decision making, has not come from legislation or regulation. I'm not saying that better laws and better regulation don't make a difference, but the things that really matter are listening to people who use services and the passion and energy that experts by experience and determined clinicians have brought to bear to set out some values and principles that guide our decision making. And in this context, there's no difference between the way that we should approach the challenges of COVID and the way that we should approach the challenges that we always face in balancing these complex issues. So particularly ensuring that throughout this whole process, we ensure that people are actively involved in their care, are respected and empowered to make decisions, that we consider the impacts of our decisions on their health inequalities and their equalities as individuals, and focus strongly on the idea that participation and least restriction guide us towards the best decisions and outcomes. And that's not because those things are just about the rights of the individual. I mean, they are, and that's critical, but actually because the evidence points us towards the fact that making decisions which are positive, proactive, based in hope and optimism, rather than risk averse and based in an anticipation of things going wrong, actually lead to safer and better environments. And the thoughts that we perhaps traditionally fell back upon, that restrictive practices and risk aversion make places safer and more effective, are misguided and don't make sense. I think one of the areas that people are probably most anxious relates to what sort of legal frameworks are available for people during the COVID incident when there's a conflict between the individual's wishes and the expectations that they should be behaving in a way that achieves a COVID safe environment. And I know that this has placed people who work and run in services in an extraordinarily difficult position, where it's almost felt like the expectations to provide safe COVID safe environments have prevented us from providing the kind of high quality and effective care that we would want to. It's not only that the restrictions imposed on people are in themselves unpleasant and take people away from care and treatment, but that the impact of COVID has taken away some of the positive treatment opportunities that would normally be available in inpatient services, which can then lead people to feel less safe, less actively engaged, and that can lead then to the sort of restrictive practices that further worsen a person's ability to participate in meaningful care and treatment. The thought that a person who is in the throes of an acute admission to a psychiatric hospital could also be forced into isolation because of a physical health issue is obviously a seriously challenging one for that person and for others, and it invokes some questions in us about what the right legal approach to take is to ensure that person's safety and that of others. And the first thing I think I need to come back to is that there is almost always a way to come on board with a person, to make them more empowered and to give them greater insight and understanding about how they might better participate in decisions about their healthcare, whether that involves an agreement around submitting to something like a COVID swab test that can enable them to be safely integrated within an environment, or a shared decision-making process about how that person who might, for example, not wish to give us a COVID swab test could then be supported to have as good an experience of their period of inpatient care as possible. Now, I think it would be optimistic to imagine that there would be no situations where it might be needed for restrictions to be imposed on a person who did not accept their need to protect others from harm by isolating themselves in line with government guidance. But I think that doesn't mean that there isn't lots that can be done to do that in a way which is mindful of the individual's rights and that promotes their opportunities to have a good experience of hospital, and that those restrictions can be for the shortest possible time. And of course, one of the questions is, for it to be lawful, what legal framework is appropriately used in order to ensure that a person who is isolated has their rights protected. And anyone who is familiar with the Mental Health Act will know that it is not intended for people who require treatment for physical health conditions. There are some circumstances in which the Mental Health Act allows people to be treated in a relatively isolated setting, but they're completely different from the expectations of COVID and would only really be appropriate if a person's behaviour was so disturbed that they could not be managed in a communal setting, or if there was a long-term risk of aggression and violence towards others, which is part of that person's mental disorder. And I don't think anyone is expecting that that would be the basis on which a person with COVID who did not wish to submit to the necessary precautions would be able to be managed safely in hospital. So the question then is, well, what is the basis in which that should happen? And I think our guidance gives some pointers about that. But I'll come back to what I've said before, which is that ultimately the guidance is there to enable clinicians and people who use services to work together to make plans which are as involved and participative as possible. Most of the time we think it would be best for a person to be supported under the protections of the Mental Health Act, but the only circumstances in which that would be lawful would be if that person's decision not to engage in the requirements around the COVID testing or isolation requirements was connected to their mental disorder, or if it was necessary for them to be in isolation in order to achieve safe treatment for their mental disorder. And there'll be lots of situations where that doesn't apply. And our challenge has been, well, you know, how can we help people to not need to be in hospital if at all possible, so that they can have the freedom of choice that they need around that. There are some powers available under the COVID Coronavirus Act, but none of those is positive in terms of the experience of care that people will experience. And we would strongly suggest that they should only be used if absolutely no other alternatives available. And in those circumstances, we'd question whether or not the person should be in hospital at all. I think there's a further possibility that powers available under the Mental Capacity Act might be used to support a person's rights whilst in isolation. But again, the question comes back to whether or not the proper place for someone to be is in a hospital setting if the issues relating to their care and treatment don't relate to the need for treatment of a mental disorder. I'm aware that I'm pushing through this at a slightly greater pace than I intended to, but I think the main thing I want to highlight before moving on to a conclusion is that if anyone does need to be isolated against their will, then that is a fundamental infringement of their human rights, their right to freedom of movement, their rights to access to a family life. And we need to do everything we can to ensure that that is proportionate and for the shortest possible duration, and done as far as possible with the consent and agreement of the individual. So we've proposed a framework for oversight of those isolations, which is intended to support those people to have the highest possible quality of life and to access care and treatment as quickly as possible in a consenting and fully engaged manner. This is not specific to whether people are detained under the Mental Health Act or otherwise. And although there are similarities between the expectations and the way that we describe oversight of processes like seclusion, I come back to it again. This is not seclusion. This is a very different process. And this framework for protection is to make sure that people who do require this really challenging level of restriction have the least possible impact and the most possible opportunity to have a shared process where they're consenting and meaningfully engaged in their treatment in a way that helps them on their journey to recovery. I won't go through the details just in order to save a little time. The final slide I wanted to reference was in relation to some specific exemptions in regard to the Code of Practice. Now, for those who are not familiar, the Code of Practice is a statutory document which sets out guidance as to how the Mental Health Act should be applied. And as Andy noted, there are some easements on the expectations which are described in the Coronavirus Act. And there are some further areas where interpretation of the Code of Practice might be amended so that people can have the safest possible care. Our core message here is that any area where a provider or an individual does feel that it's appropriate to deviate from the recommendations of the Code of Practice needs to be weighed in the balance as an individual issue relating to the harm that might befall the person or others if we were not following those recommendations. So, for example, if following the expectations of the Code of Practice during the COVID incident led to a delay in accessing treatment or harm to the individual, it might be reasonable under certain circumstances to deviate from that. And our guidance has included some examples of best practice that enable us to make sure that we put people at the centre of those decisions, protect them in every way possible, and only do this when absolutely necessary without needing to recourse to blanket restrictions. So sort of to sum up and hand back, I think what I want to reflect is that our guidance is intended to provide clarity. The one common thread throughout it is that taking a human rights-based approach means thinking about the proportionality, least restriction principle, and likely effectiveness and lawfulness of any decision that we make. And that in every instance, trying to engage people in shared decisions about their care and treatment leads to better care and fewer restrictions. and that if every decision is made on a case-by-case basis using the skills and expertise of experts by experience and clinicians, then there is a way through almost every problem that preserves the rights of people to have the best experience of care. And I will hand you back with thanks.
Thank you very much, Daniel. That was very complicated areas that we're all grappling with in this current time, that you've really made much more easier to understand some of the nuances and some of the challenges that the system faces, but equally about how important it is to raise right at the forefront of our thinking human rights. I would like to sort of interact that somewhat with our responsibilities around equalities and equitable decision making, interacting with the human rights considerations, particularly in this area. And I think that that's something that we'll need to come back to. We don't have time to grapple with that now, but that's actually really important, because the demographics of what we're dealing with here in terms of the differential impact of COVID on different communities is in itself an intersectional feature of the implications of this guidance and the thinking in the decision making therein. I'm going to move briskly on, and I would ask that presenters, when you're not speaking, could you make sure that your microphones are off? Some people are struggling with hearing our attendees. And I'll move into Kevin Cleary. It might be that we might go somewhat a little bit over our time today, and I might be leaving, Andy will take over. But I think that the issues that we're going through here in this webinar are so important that if we could just maybe go over time, taking up some of the time that we got in late, and bearing in mind our technical sort of like world now, if people could bear with us so that we can get the fullness of the important work our presenters are sharing with us, if you bear with us on that note. And without further ado, Dr. Kevin Cleary, please.
Hello, thank you very much, Jackie, and hello to everybody. I'm Kevin Cleary. I'm the Deputy Chief Inspector for Mental Health, and I'm going to talk now a little bit about mental health, COVID-19, and the risk to human rights. So many of you will know about the work of the Care Quality Commission. We are the independent regulator of health and adult social care. And we do a number of things. We monitor and inspect all regulated services in hospitals, but also in adult social care and primary medical services. We have a number of legal powers given to us, which we can use to enforce if we find that the care that's been provided is not adequate. And independently of that, we also provide a number of publications about various aspects of quality in healthcare on a regular basis, and there have been a number in mental health. And very soon we will be issuing a publication in relation to restraint, seclusion, and segregation. So obviously, for everybody in England, this has been a very, very difficult time. And we've all been aware of the impact upon patients, service users, carers, hospitals, staff, the whole healthcare system. And things moved quite rapidly at the start. And we had to adapt quite quickly to a very new situation for us. We paused very briefly in mental health routine inspections, but that's not to say that we stopped regulating healthcare. And the reason that we paused inspections was we wanted to support the NHS and other healthcare providers to keep people safe. We wanted to allow them to focus on the emergency that was unfolding. We wanted to avoid our inspectors spreading the virus inadvertently. And right at the beginning, there was a demand for what was quite scarce personal protection equipment. And we wanted to make sure that we weren't using resources that would be better provided to healthcare providers. However, we did still respond to risk. We continued to have very regular conversations with healthcare providers, with patient groups, with mental health advocates, and we built up a picture of how services were coping. We introduced something called the Emergency Support Framework, which was a structured tool which allowed the same conversations to be had with providers of healthcare and adult social care. And actually, we returned to doing risk-based responsive inspections very quickly. And we have continued to do that. So on the basis of information that's flowing into CQC, we have been going out on a very regular basis to have a look at services where we have significant concerns, and have taken quite decisive action where we have found services not to be providing the level of care that we would expect. Obviously, it's very important that we share our learning, and we have been doing that. And I think there was a publication, one of our insight reports is in the file section that everyone has access to, and you are free to download that. Those files are also available on our website. A key part of maintaining quality in healthcare, even in difficult times, is being completely transparent about what we see and what we find. And we are continuing to do that on a regular basis. Of course, human rights, these are fundamental things that we are all entitled to. The fact that you are a patient doesn't in any way really, I think, impact or should impact upon your basic human rights. Our Mental Health Act visits, which are an important part of how we monitor the provision of mental health care in hospitals, obviously had to be changed in some ways, because at the very beginning we weren't able to go out. And normally we would go to every single provider of healthcare, mental health care, once a year, and go to each ward actually once a year to do a mental health act visit. So we had a virtual mental health act visits up and running quite quickly. And though there are some limitations with this, actually they have gone really, really well. So the mental health act reviewer will make contact with the ward, will talk to patient service users and carers who might be on the ward, and also talking to the mental health advocates who are making contact with the wards as well, so that we sort of form an overall view of what's happening in that environment. If the mental health act visit threw up concerns, then we would do an on-site visit, either by the Mental Health Act reviewer or by our team of mental health inspectors. The problem, of course, is very early on, very few people were going into services, and there's always a risk around closed services, and we are aware of a number of scandals that have occurred fairly recently, which reflect really the closed nature of that culture of that organization. And so we have really made sure that we're sort of focusing our efforts on those more closed cultures, because it's critically important that we don't lose the surveillance of those types of services. And also we have raised issues around blanket restrictions, around visiting, and contact with family during these times. And we are aware that there were issues in relation to sort of the need to shield, the need to make sure that infection is not spread through any more widely than it has. However, the blanket restrictions can impact severely on patients. And so we have made a full statement around how blanket restrictions need to be avoided. And we have commenced a full program of focused inspections. I have personally been out on one to see how services were coping. And it was a good experience to see how things were going in services. So one of the things that CQC does is that we have to be notified of all deaths of patients who are detained or liable to be detained under the Mental Health Act. And between 1st of March and 4th of September so far, we've been notified of 94 deaths from mental health providers of patients that were believed to have died from COVID-19. And we have published this in one of our Insight reports. And so here you can see in a graph, the grey bars are the patients who've sadly died from COVID-19. As you might expect, the peak there is in April, when the peak was in the general population. And for detained patients, the pattern was exactly the same as it was for the general population. It rose in line with what had happened in the general population, and then it fell back by May. And again, this is just a sort of a different way of looking at this, but this shows weekly deaths compared with the average. And as we all know, deaths rose sharply and then have fallen back to the average, which is again reflects what's happened in the general population. So what have we learnt from this crisis? So the voice of people is really important, and the voice of care providers is really important. I personally was very concerned early on that we were losing the voice of patients in all of this. And I think that it's really important that patients are able to tell us what's happening. The importance of sharing information with everybody so everybody can see what's happening, and the importance of being transparent, as I've said before, because you cannot maintain quality if you're not being transparent about it. Local systems, the impact is beyond the providers of care. It's all over the system. And transparency promotes learning. One doesn't happen without the other. And thank you very much. I'm going to hand it back to Jackie.
Thank you so much, Kevin, and fairly comprehensive. And it's really reassuring to hear that the CQC has found ways to be agile within this period to maintain some of its function, because we do need to know that the scrutiny that comes from CQC is actually still ongoing, and it's really even more needed during these times when actually so much can happen outside of sight. It's really important to make visible. So I'm gonna move on helter skelter and move on to Dr. Andrew Hida. Haida, I don't know how to pronounce your name, and I'd welcome you to introduce yourself.
Hi, Jackie. Yes, it's Haida. So welcome everybody. Thank you for coming. My name's Andrew Hida. I'm a consultant clinical and forensic psychologist, an approved clinician, and I work as clinical director for Ludlow Street Healthcare, and we're a medium-sized provider within South Wales and the southwest of England for people with significant mental health difficulties and learning disabilities. So we run a number of inpatient sites and a lot of social care sites as well. I'm really grateful for the opportunity to be able to talk about this today, because it was one of my huge concerns really at the beginning of the pandemic, in regard to how we were going to preserve the rights of our service users throughout the period. So what I'm going to do is going to go through, and this is very much a presentation about actually what happened. So I'm going to try and focus on real events here and case studies that sort of resonate with the theme of what we're talking about today. And I'll just try and whiz through as quickly as I can and not kind of pad it out too much, because there's quite a lot of detail in what I'm going to say. So the first thing is that, you know, we need a set of references to manage a pandemic, I guess, and as mental health clinicians, you know, we have, as Dan and Kevin have both mentioned, existing codes of practice. So we have the Mental Health Act Code, we have the MHA Code, and obviously we've got the Human Rights Act. And of course, none of those were actually designed to help mental health services navigate a global pandemic. They didn't have that in mind, and they've kind of come up against this operational and clinical situation, you know, we found ourselves in. So, you know, I found myself kind of going back really in terms of a general knowledge of ethics as being very important in clinical practice. You know, how we behave as clinicians, particularly when we coerce people, is a reflection of the ethical assumptions of the society in which we live. And sometimes those assumptions require challenge. So I think it's just about being aware. And I was sort of reflecting on this a lot during the pandemic, because I worked all the way through clinically. You know, what was informing my thinking about the decisions that I was making? And really, we've been up against some pretty profound, you know, questions about the relationship between individual rights and the state. And also, you know, very profound questions about the ethical nature of humans and, you know, human rights, and, you know, what are they? What are human rights? And I think, you know, those questions are things that can seem very abstract, but in the context of actually, you know, running and managing complex mental health services through this period have become extremely concrete and real. You know, so what were we worried about at the beginning of all of this? Everything really that Dan and Kevin and Andy have referred to. So, you know, clinical cover, you know, would we have enough staff? Clinical governance, you know, upholding patient safety requires people to think in a slow way. You know, we were concerned that if we just started focusing on COVID and neglected our general governance, that would compromise safety and quality. We were concerned about right to family life, people losing access to their family via bans on visits. We were concerned that mental capacity wouldn't be considered in our inpatient services as a factor in supporting people to make decisions. And we were also concerned that, given that everybody's anxiety had gone up so much, that our rates of restraint and physical intervention would increase. So those were our worries in our inpatient services. In social care services, very similar in terms of clinical cover, in terms of clinical governance, in terms of right to family life, mental capacity, and in terms of restrictive intervention, we were more concerned about restrictive practice within social care. So, you know, people not being able to do things that they should be able to do, and based on assumptions that they were unable to make decisions for themselves rather than proper capacity assessment. So those were our concerns at the beginning. So what we did, I'm going to whiz through this. This kind of gives an overview of what we did. And I think it's fair to say, you know, lockdown was a predictable event, really. We were planning at the end of January for significant social disruption from the pandemic. So we constructed a concern list across all of our services of people who might struggle to understand or engage in increased restrictions. We created care plans for everyone in partnership with service users to prepare for those. We developed clinician cohorting lists. We constituted standard operating procedures for all of our separate services and ensured that the principles of the MCA Code and the MHA Code were incorporated into those. We directed the continuity of clinical governance and sort of separated that off from our strategic thinking around COVID in order to ensure that normal clinical governance was maintained. And really importantly, we directed the continuity of our corporate clinical ethics committee and emphasised to all MDTs that they should be making full and frequent use of that. We raised some concerns externally about the pivot of restrictions towards elderly social care with some of the government guidance that was coming out. Wasn't always appropriate for our tertiary mental health service users, and I think that's a difficult issue, but we did raise it. We preserved on-site working for our clinicians. We didn't work from home. We communicated with all families, carers and service users to support video communications. We directed that all service users must be offered a care plan with timed regular family contact. So rather than just say, yes, we will help you use video to contact your family, we made sure that there was a care plan with a specific time to ensure that it wouldn't get kind of overlooked. And we did a lot of purchasing of additional IT facilities. So that's kind of what we did. Now, in terms of what happened, there were a few case studies really that I thought that would be helpful to kind of talk about, which I suppose highlights really the sort of human rights and ethical concerns that we've all been grappling with. So first of all, we received a directive from Welsh Government. You can probably tell from my voice that I'm speaking from Wales, advising all transitions to social care sites from inpatient services must self-isolate even if they'd had a negative test for COVID and they were being discharged from a COVID-free hospital to a COVID-free social care site. So immediately we were concerned about the lawfulness and the rights compliance of that, given that these were people who'd had a negative test. Obviously that balance between risks to mental health and the right for somebody to only be detained in a hospital if they absolutely have to be with COVID risk. And we felt this sort of balance between Article 2, right to life, and Article 5, the right to liberty, was important. So we escalated to Public Health Wales to raise those concerns about the fact that we may be in a position to follow that guidance of using restrictive intervention, unlawfully, and creating risk. And Public Health Wales agreed to review a protocol that we wrote to support decision making when discharging people. And that protocol balanced rights, capacity, and risk to the person of restrictive intervention if they didn't isolate, even though they were COVID negative. And that was signed off and agreed by Public Health Wales. So it's a very helpful kind of joint decision. And we've been meeting weekly with Public Health Wales throughout this as an organisation to run all these ethical issues past them. The next one, somebody subject to a DOL authorization, hadn't had family contact for months, inability to adhere to distancing and PPE for that particular individual. We were very concerned again around the impact on that person's mental health. Again, we discussed with Public Health Wales to ask if we could put in place a specific risk assessment around a potentially non-distanced visit. Again, that was reviewed, signed off, and the family visit took place. So this was just a kind of a process that we were going through very regularly in ensuring that we were raising concerns, reviewing individual risk assessments, and then taking decisions that were hopefully in the interests of the people that we were supporting. Finally, towards the end of the lockdown, the initial lockdown, the police stopped one of our staff teams who were on a therapeutic drive with a service user who just couldn't cope with interruptions to routine, and were advised they were in breach of guidance. And at that time, the College of Policing had actually put out guidance saying that visits such as that should go ahead. So we contacted the police and advised them of their own guidance, and then those further trips were not stopped. So, where are we now, I guess, in terms of thinking about, the situation in the mental health system as we move into probably another difficult few months? The ship didn't sink, but, we're in the Strait of Messina, if people know the myth of Scylla and Charybdis, between COVID-19 and human rights infringements. We have operational and clinical protocols that are protective of rights in place, and we can flex those up and down. But the current risks, as I see it, having been through this, is that a further period of high community transmission, there's a lot of human factors for all of us as sort of workers, leaders, service users, that bear down on these sort of rights abuses that we're vulnerable to. So one is very sort of unthinking obedience, really, to any guidance that comes out. Fear-driven reasoning is obviously extremely dangerous when it comes to making decisions that impact on people's rights. Fast thinking generally, so not taking the time to actually think about what you are doing and what rationale you have for making your decisions. And we need to be careful that negative freedoms, freedoms keeping people free from things or risk, overwhelm positive freedoms, which is maintaining people's freedom to do things. So just to finish off, really, a helpful view of human rights for mental health in a pandemic. We've not thought about this before, probably most of us, but I've been thinking about it a lot, and I'm sure all the rest of us have. And I am going to lapse into this last slide, I'm sorry, into some sort of formal ethical jargon, so I apologize for that. But human rights, as we talk about them, are based on underlying assumptions of what we call deontological ethics, which is that there are these absolute moral laws that define what is right and we have to follow them. But in a pandemic, our clinical decision making is driven by this sort of consequentialist reason, so sort of thinking about what are the consequences overall for the decision. And sometimes, and government obviously works in this way a lot, is thinking about utilitarian decision making. So what are the competing outcomes for the individual against the overall outcome for society? So I think, for us as in mental health services, that we might usefully see ourselves as having constraint-based responsibilities as clinicians and leaders. So this is about ensuring that we exercise the responsibility of our duty to intervene, to provide treatment and care for people's mental health problems, while being aware of what of the constraints are posed by the additional ethical calculus, as I'd call it, of a pandemic around us. And the day-to-day decisions that we have to make are about the reasonableness and lawfulness of the constraints that are placed upon us as clinicians, as leaders, and more importantly, on the people who use our services by the pandemic planning guidance that is obviously not necessarily been pivoted around the needs of the mental health system. So I think it's just about being aware, really, what are our duties in terms of how we apply these, constraint-based responsibilities that we have. So ensuring our staff are aware of what the articles are of the Human Rights Act and can either give a rationale for decisions based on them, or they can tell other staff about why the decision that they've directed must be followed under human rights law. The need to challenge authority, and I would include public health bodies in this as mental health clinicians. Public health protocols may represent reasonable constraints on rights, but not for others. And that might be within the same service. So emergency rules may not be either lawful or ethically reasonable. And also to be aware that ethics and emotional responses are linked. So our ethics derive from our natural human group behavior and our emotional functioning. So I think it's probably fair to say to colleagues, if a clinical or service decision feels wrong, even in the context of a pandemic, it may well be simply wrong. So that's it in terms of what I was going to say, but I just wanted to finish off because you could end up very abstract with this, with just some sort of visual oversight of what happened really during the lockdown. So a visual diary of this is the reality of what it was like, so here's a bench that somebody painted during the lockdown of somebody who I support. He was refusing to leave his flat. He was so scared. So sort of painting and building the bench was a real way for him to get over his fear of just moving outside the front door. And I just remember that feeling very surreal at the time. This was in the depths of the lockdown in April. The other one was taking somebody who I'm RC for, responsible clinician, on a walk because, again, somebody was very scared to go out. And this was taken in a part of the Rhondda Valley that had some of the highest death rates in the UK of COVID. And I remember just how strange that experience was of walking around a usually quite busy area and there's nobody being there at all. Another image, of just how, as humans, we try and impose structure. So this is our attempt to kind of ensure that we maintain therapy provision in one of our inpatient sites. And I took the photo because I just thought it represented this sort of need in this, when everybody felt like a cork, in a storm. And that activity probably served to reduce our anxiety that we weren't going to serve the people that we're, employed to help in the way that we should do. Another one of just how anxious we all were during that period, and trying to make decisions while every day you're checking your SATs is bound to influence your decision making as a mental health clinician. And what an abnormality that was really for mental health clinicians to be in this sort of world where, all of these issues come right to the forefront. And then finally, an image I took, which really I thought represented the challenge we face socially, which is bound to impact on our services, of these posters that appeared in the middle of a deserted city centre in Cardiff about everybody being kind. And this particular one was defaced with, kind of political slogans about how the government weren't kind. And, I'm not making any political statement by showing that slide, but I thought that it was a representation really of how, this kind of sense of divided societies and ideologies don't have a great record for maintaining human rights. And I'm just aware of those issues that are bearing down on us all, on top of trying to support people through this pandemic. So, that's the kind of direct practical experience of trying to maintain human rights through the pandemic that I've tried to illustrate in the talk today. And that's it.
Thank you so much. That was really very useful in the sense of making it live in terms of practice around working through the care and decision making for people in the context of COVID. And thank you very much for that. And also thank you for sort of bringing an ethical dimension to the arena. And I'm just here with the whole array of questions, largely rotating about what does this mean for the very long, unattended, discriminatory experiences of people who come from racialized identities or other identities experiencing but in particular mental health detention, and that interaction with human rights in the interaction under COVID. And I really don't hear where those kind of demographic differential experiences are being considered or grappled with in the way that it needs to be grappled with previous to COVID, but actually even more reinforced because of the nature of how we're all aware of Floyd, and how we're all aware of the disproportionate impact of COVID on our most oppressed groups, actually. And what does that mean in terms of human rights, in terms of mental health and COVID and the care, and our thinking from an ethical position, ethics that are informed largely by Eurocentric ethics rather than ethics which is an inclusive space. So all these kind of things like tease out further questions for us to explore, and I'm grateful for the richness of the panel in putting some of these things on the table. We don't have much time for questions, but I do want to tease out one or two before I jump off, and maybe Andy, if you want to pursue a little bit longer post me coming off. I've already extended, let them know in my other appointment that I'm going to be late because I'm just finding this so fascinating but so utterly relevant. Learning disabilities and people with dementia and comorbidity in this context. Could we have a little bit more of an exploration around that in the context of human rights, knowing that there have been real challenges around tuning into those particular cohorts? Anybody from the panel, could you speak to that? A couple of questions in the chat on that.
Shall I start, Jackie? So really important to make sure that we don't just think about this applying to people with mental illnesses. We've also included guidance about people with learning disabilities, autism, dementia, and with trauma-related conditions that we might call personality disorders. I mean, as you say, this is affecting everyone, and that's where I think it starts to get more complicated in terms of what frameworks are the right ones under which to ensure people's rights are protected, because clearly there'll be people with dementia who are supported under mental capacity frameworks like the deprivation of liberty safeguards, which again are not a perfect fit right now and don't protect all of the rights of individuals. But I'm going to keep coming back to that kind of common message, which is that firstly, what are we doing supporting people with learning disabilities and dementia in hospital if they don't have a treatable condition which needs to be in hospital? And I think the first question needs to be the one we always ask, which is how do we enable people to live free, positive lives in their own homes? And secondly, the framework that I think we've put together is intended to make sure that people who do need to have restrictions, as part of our duty of care towards them and others, that utilitarian responsibility that Andrew noted, I think the framework there makes sure that we do put their needs and interests first and foremost and give them the best quality of life whilst making sure that they do get the support they need during this time.
Can I come in that as well,
yeah,
Jackie?
Please, Andrew.
So what our organisation looks after people with learning disabilities and mental health problems, and one of the things that was really helpful about what we did was ensuring that we had a standard communication protocol for our learning disability site specifically. So there was a lot of material that came out for the public about COVID. It was constantly being updated, particularly during the beginning of the pandemic. So where there was a lot of helpful resources actually that were published by a number of organisations, Build, for example, around people with learning disabilities. So we just ensured that all our staff had access to a central site where if they had any question, any service user had any question about anything, there was always a quick and easy way to access the right kind of communication resources to support knowledge and understanding. I mean, that's just a small thing. I mean, it's a massive issue, I know, but that was something that we felt was important, was just not handing people a piece of paper or expecting them to be able to just listen to the news and then understand, you know, what to do and what was going on. Because a lot of our clients with learning disabilities were watching the news and then becoming very fearful and scared. So, you know, it was about ensuring that they had appropriate access to resources that would help them to understand the situation.
Okay, and perhaps I wonder if we could tease out a bit more in relation to older people and dementia also, and our response, considering the disproportionality in relation to the age-related impacts of COVID and mental health. Is that something that people have a view on in terms of human rights?
It's a huge question, isn't it?
Anybody from the panel can speak to this.
So I think one of the things I will reflect is that the challenges I think that services have faced in coming to decisions about whether people should be in a hospital where they may be exposed to a risk of other people having COVID, or in a care institution in the community where they may be exposed to a risk, have been extraordinarily challenging to navigate. And I think the first thing to say is that we shouldn't try and simplify that. What I have seen in practice is a lot of very compassionate care. And the things which have really made a difference, I think, to the experience of people with dementia when they've had to be in an institutional setting, is the opportunity to communicate with their loved ones, the opportunity for them to have access to virtual means of communication, if not face to face, and the flexibility that I think Andrew's alluded to. So I think what's really key is that some people felt that the guidance and the requirements around the first wave of COVID prevented us from allowing people access to the outside world or to their loved ones. But I think what we need to say back again is no, that's actually necessary. That's part of their care and treatment. And there are quite reasonable bases why you would deviate from those lockdown isolation requirements, and actually fundamentally keeping people in touch with their loved ones and in touch with the things that ground them and help them to overcome the impact of their dementia is an absolute must do, regardless of the balance of risks associated with COVID. And I think we've seen some great examples of that. But as Andrew says, people have needed to be liberated to do the right thing sometimes.
Yeah. Jackie, can I come in on that? Because I think that's right. That contact with families and loved ones is really,
Thank you
really
very
important.
much for that thoughtful. Yes, please.
Is really, really important. And people may have to think innovatively about how you sort of maintain contact with the family during COVID. I think we've now got an opportunity to rethink, and services have an opportunity to rethink actually how they might do things differently. What have they learned from the first wave? And it's really important that sort of patients' voices and carers' voices and service users' voices are heard at this time, so that sort of that helps support the services to think innovatively about how they might do things differently. No one ever gets it right the first time, you know, but you learn incrementally, and I think that's really important. Thanks.
And I think one of the benefits of such an awful situation is that we are all really challenged to continue to learn and to learn really robustly. And I think that's what we've kind of like got here, is a platform where everybody's sharing their learning, the good, the bad, and the ugly of the experience, and recognizing our own humanity in not being perfect, but actually recognizing at the same time that we've got significant growth areas to continue to explore in the best interest of the populations that we serve. And within this context, so much wonderful things have been done, which you have shared in terms of the guidance and practice and interventions that you've been making. I must celebrate the panel, because that very much is what's coming through the chat, is to really give thanks to each of the presenters. So before I jump off, I really want to make sure that I say that I'm very grateful for being here amongst you. I look forward to working with you post this webinar, in light of some of the comments I've been making, which I notice nobody really can sort of embark on any further at this moment, but that's all right. I think that there is a question that, before I go, I wouldn't mind teasing out. We're where the use of having relations with advocates, and some of the IMHAs on the chat have actually really valued that connection. I'd sort of like to just ask the panel, what are their thoughts about advocacy as a way of making sure that the patient's voice is central to the thinking and the decision making and the improvement agenda of each of the providers. So that whilst I hear that commitment, you're aware that one of the recommendations from the mental health that review, which was agreed by government Theresa May, was for culturally appropriate advocacy. Can we speak about the concerns, which was really around the concerns for racialized communities in interaction with the mental health service provision? Is there a view on where this is at now, or the relevance of this, particularly during the context of COVID, and what are your thoughts? Kevin, I wonder if you might speak to that initially.
Sure. So the role of the independent mental health advocate has been critically important to us, and I think to patients and service users during the first part of the pandemic, because in some ways they were a really important ears, and telling us what was happening, what was going on in services, and we use that to help inform sort of our decision making. It entered into part of our sort of risk assessment. I think that, if I'm honest, the discussion that we've got going around the importance of the voice of particular communities, so the AME communities, and its impact upon how mental health services were being provided, and of course it's a link to the important work that's on with it. I think that got lost early on as people just sort of focused on surviving. But now that we're sort of through that first phase, and before we get into the second phase, I think it's really important that we try and get that discussion going again, because it has been lost, I think.
Thanks for your honesty. I don't know whether other members of the panel want to comment on that particular aspect, but it's okay if you don't.
Can yeah, on the issue of advocacy generally, one of the big challenges has been maintaining adequate advocacy when there are limitations on visits to health and social care sites. And I think what we have now are some new guidelines around this notion of essential visits. So what counts as an essential visit? And I mean, certainly in Wales, essential visits are not kind of codified. There's some kind of sense that they're to do with where people's health is at serious risk. But I think that there's a case actually for saying that advocacy for people who are detained by the state in some form, that access to somebody who can have a meaningful conversation with them in a private space is an essential visit. Now, and for that to happen, I think the advocacy organizations, who can sometimes, I think, feel sort of diminished in comparison with, the visiting clinician, might be better having their own authority to kind of say, well, actually, I do need to see this person, and I know that these guidelines are in place, but you need to find a way to make it so that I see them. And I think that's reasonable.
And I think that's reasonable as well, Andrew, just to extend the point in the context of human rights and having that voice differentially from the practitioners in the context of ensuring the implementation of human rights, really, from an objective kind of like position. In relation to the power relationships in these decision-making contexts. If we're really talking about human rights, we're actually also talking about power relationships and the spectrum of rights and where that rights, how those rights operated in relation to that power relationship. So thank you actually for your reflection on that. I'm going to jump off. I've been held by you, but I need to move. And thank you so much. Andy, could you take on from here, if you may?
I'm assuming we may, of course, Jackie, brilliant, thank you. And I suspect we may have come to the end of our time, because I noticed that people are beginning to have to go. And this may be a good point to thank everybody, and some really interesting, very, very focused content, which feels like it's really relevant to everyone here. I know not everyone will have had a chance to get every question answered, but I think we've probably had a really rich and thoughtful conversation. I'm hoping the presentations will all be made available to everybody who's been here. And our colleagues at GovConnect have worked through some rather challenging circumstances. So also huge thanks to Rob and the team for getting us together and actually saying, let's have this conversation about human rights and mental health at this time. It's not a conversation we've been having as much as we should. So really very well done to them, and thanks to everyone who's been a part of it today.
Thanks, Andy.
Thank you very much, and
Goodbye.
goodbye.
Take care, stay well.